And we are online with everyone. Good morning, everyone. I will not be able to see you all right now.
How are you?
I will not be able to see your texts right now. Please make sure you save your questions until later on, like I have discussed. And I'll be walking over there so you can see it. So before I start into the slides, what I'm going to do is just kind of introduce you to a assessment.
See my chicken boots?
We're going to introduce you to an assessment. Kind of show you what you are looking for, how this is going to work, and what you should be able to do, at least have an idea of how to do by the end of this semester, backwards and forwards without looking at a book. So I want you to be able to do that, okay? So you're going to have a lot of time in lab discussing this. You're going to be able to have an idea of how to even knock on the door, let alone talk with your patient. If any of you are nervous with talking with your patient, you'll get over it pretty quick. So I'm just going to knock on the door and get started, okay? Knock, knock, knock.
Morning.
Morning. How are you today?
I'm good. How are you?
I'm good. I'm Dave. I'm going to be one of your nurses today. How you feeling today?
I'm just peachy.
Just peachy. Why are you here then?
Because I broke my leg.
Oh, I'm sorry about that.
That's okay. I didn't tear my chicken boots.
Didn't tear your chicken boots,
No.
but we're going to have to take a look at that today.
Okay.
So just toe of your leg today, okay? Well, I'm going to have to still look at you from head to toe, make sure nothing else happened.
Okay.
Did you hit your head or anything?
No, didn't hit the head. I had my hat on, so I didn't hit my head. I didn't mess up my hair.
Oh, you didn't mess up your hair?
No.
Okay, well, that's good to know. Is there any other problems you're having today?
Nope.
Okay. Well, what I'm going to do is I'm going to just start at your head, and I'm going to be touching on your head and moving my way down. If any of it hurts, which none of it should, please let me know, because that way I know something's wrong or not.
Got to take my hat off.
I would like you to take your
Okay.
head off.
I'll take my hat off.
Ooh, look at that hair.
See my braids?
I see your braids.
All right.
I like it. You keep your mask on all the time?
I can do that.
Okay. Wash my hands. Can you tell me your name and date of birth?
My name is Allie Mae Clampett.
Allie Mae Clampett. When's your date of birth?
May 14th, 1966.
1966. Okay. Just one second. I'll make sure everybody's in. I see smiles. I don't know why people are smiling.
I don't either. You need to take this seriously, folks.
So, again, if any of it hurts, let me know. It
Okay.
shouldn't, but wash my hands.
Don't mess up a braid.
I won't mess up your braids. I will do my best not to. I'm not a hairstylist, though. I'm a nurse.
Okay.
We can let you know about some good hairstylists that are here. Okay, so I'm feeling around the skin, see if there's any pain. I'm making sure there's nothing happening with it. Now, I know you got your mask on, but I do need to take a look at your nose and your mouth.
I'll hold my breath.
You'll hold your breath? Okay. Go ahead and take that out for me. All right, I'm looking in your mouth. Say, ah. Oh, that tongue. Look at those. All right. I'm looking in your nose. Can you open your eyes for me, please? And look right here at me, okay? I'm using my light, and I will explain everything that I'm doing to you. Again, this is more, I'm explaining it while I'm doing it, so she has an idea. But you guys will be getting a lot more in depth to know what I'm doing and why. Normally, I would do this lecture in class, and you'd be surrounding this patient to understand what I'm doing and what I'm looking for. All right, keep your eye right here. Perfect.
I made me go cross-eyed.
Uh-oh, we're cross-eyed. I'm just going to have a headache and all that. Okay. All right, you put your hands out for me. Put it out like that. Okay, good, good, good. All right. Can you grab onto my hands? There we go. Grab on. Now grab on tight. Squeeze, squeeze, squeeze. You're not going to kill me. Perfect. Try it again. Don't hurt me. Okay, perfect. Okay, now push against me. Pull against me. Good. Okay, good, good, good. Now relax your hands for just a minute, okay? Okay, just move your wrist. Does that hurt at all?
Nope.
Okay, how about when I move your fingers? Okay. How about that?
That's fine.
Okay. Can you do that on your own? Good. Can you go like this for me? Move those arms. Don't hit the bar, though.
Okay.
Good, good. All right.
It's like flying.
It is like flying. All right, let me see your hands again. You got those pretty nail polishes.
I don't chip it. I just did that.
Just did it. Who did it for you?
My turkey likes that.
Your turkey likes it? Oh, okay. Okay. Let's see your other hand. Good, good. Whenever I check anything, I'm checking everything bilaterally, which means both sides at the same time, to make sure that they are equal. I should expect if I have a pulse that I'm going to check, I should expect the pulse to be equal on both sides. So, check this. What watch is that?
It's one that tells me my heart rate.
Good.
Sometimes I can tell time on it if it's got the numbers on it.
Does it have numbers on it?
It has numbers on it.
Okay, does it have a second hand?
No.
Oh, it's one of those digital thingamabobs.
Yeah.
Good. Okay, check your wrist again. Out. Good. And then can you do that for me on that arm again? Look at that. Move that thing. Move it. Okay. I'm going to start at your neck now, okay?
Okay.
Taking a look. Put my hand on one side. I'm being very careful, which I'll explain to you all when we get to that point, but I'm only doing one side of the neck at a time. Got my thingamabobber here to help us make sure I can hear you, okay?
Is it beating?
I don't hear no breathing. I hear some breathing. Can you hold your breath for me now? Good. Good. Okay. All right, well, I've got this in. I'm going to listen to your heart. I'm going to come to the other side, though. I feel like they want to watch me on that side. All right. And I'm listening to the heart right now. Good. Can you sit up for me? Good. Normally, whenever you get a chance in the hospital, you make sure they have that gown open so you can also look at their skin, okay? I do not like or do not want you going over the shirt when you assess a patient. But she's got some pretty overalls on, which is very difficult. Deep breaths. There we go. And one more after this. Good, 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 good. Stay up for just one more second. Any of this hurt?
Nope.
Good.
It's fine.
Just fine. It's just your leg, it seems like. Okay. Now, at this point, they're normally going to have a gown on. So you want to show their abdomen. You want to make sure that you take a look at this. And again, I will go step by step through this. I'm just introducing it to you. So, I'm taking a
I
look
ain't
at
taking
your
my
belly.
clothes off.
No, she doesn't want to. So we're going to take a look at it. Thank you. So I'm going to take a look at your belly first. I'm going to look at it first. I see everything. Now I'm going to take a listen to it.
Breakfast is in there.
And you will find an order of assessment to help you with this as you go through it. After this lecture today, come back and watch this video again and see the order of things that I'm doing. I will describe the order I'm doing, but you'll see how I'm doing it in a very specific way. I'm going to put my hand on your belly, okay? Tell me if it hurts at all.
Nope. Don't give me gas.
Uh-oh. If you got to pass it, it's okay. You're in the hospital. We'll make sure it's taken care of. You all right with that? Good, good, good. Okay. Good. Now, what I'm going to move your hat for, you going to put it back on? Good. All right. What I want you to do is, can you move your legs? Move your leg up. Good. Okay. How about the other one? So your knees are doing good. Okay. Okay, good.
They're not broke.
I'll put my hands on your hips for just a second. Does this hurt at all?
Nope.
Good. So which foot's hurting?
This one.
That left one?
No, this one.
Oh, that one? Oh, that one. Okay. Well, I'm going to start with the not hurt foot.
See my
Okay?
socks? They're blue.
They're blue socks. Well, okay. Are you sure those are blue?
No.
Oh, okay. Let's take a look at this one. I'm going to take a look at both these. I would take these off and get showered with dead skin cells. And I'm going to go through and I'm going to feel the bones. And all I'm doing is kind of putting pressure above and below the bones themselves, just to make sure they don't hurt at all. Kind of go them through the rotations, move them through. She can do that as well. Can you do that on the other side? A little bit less on this side. I can notice that. And again, I push on both sides. I move the foot until she tells me it hurts too much. Right there. Okay. And this, again, we would go through this. And now, what have I found today? I see that you have good range of motion, you're pulses are good, you have a good sense of humor today, your leg seems to hurt you though.
That's what I said.
Oh, that's good. You able to pee okay?
Yeah, I could pee just fine. I could pee by the trees. I could pee by the bushes. We ain't got an outhouse.
You able to poop okay?
Yeah, I can poop every day. We have it for my coffee like clockwork.
All right, you fertilize your own fields?
Yes,
with that?
I do.
That's right, you gotta make sure. Now, something that, when you guys go to clinical, I want you to know this. You're going to have a lot of time doing this. Again, this is a quick introduction of this. But usually what I do with the head to toe is I will step back when I'm done, and I will look at my patient while I'm talking to them, and just kind of break them down. I'll look at the head, then I look at the eyes, then I look at the nose, then I look at the mouth, then I look at the ears. I didn't look at the ears. Then I look at the chest. Okay, then I listen to the heart, lungs, like literally go through anatomy, physiology. Think about what organs are there, and did you assess them? Arms, range of motion, musculoskeletal, did I go through? I asked about urine, I asked about stool, and she's not complaining of those, so I'm not going to dive into that. Your mental status as well. So she's been talking to me. She's been able, by just talking with them, you can find out, I asked her date of birth, I asked her name, which did match to my records, and then we can just kind of chat. If she tells me a little bit about what she does and just kind of talks to me, I get a lot of information about their neurologic status, okay? Good question? When was your last menstrual period?
1986.
Oh, so it's been a little bit.
It's been a little bit.
Do you have any vaginal bleeding or discharge?
No. Mm-mm.
Okay.
That don't work anymore.
It don't work anymore? Well, just make sure you tell us if something does.
Okay.
Okay? All right, great. So, but I've gone through and explained everything. I see lots of stuff. Hi, Miss Patient. Nice boots. I hope all my patients are like you. They won't be.
No. And that's a good thing.
Now, if you're taking notes, stop right now. This is a bad assessment I'm about to do, okay? The other one was a quick one. You've gone in, talked to your patient, and the nice thing is when you're working, you'll have a computer in front of you. If you forget something, you go through every assessment, you're like, oh, I forgot to ask this. Go back in and ask the question. It's not a bad thing to have to remember that. We're all human, okay? Excellent acting. That's not acting. This is Dr. Harrington. This is your second-year instructor. This is what you get. All right, so just a quick one, just for a little bit of fun, and then we'll go into the actual slides. Hey, Miss Lady, how you doing today?
That's not my name.
Miss Lady, it's okay. Oh, I'm sorry, Miss Lady. What's your name?
Allie Mae.
All right, ma'am. Ma'am, I've got to ask you a few questions, okay? Tell me what's bothering you today.
My foot hurts.
Your foot hurt? Okay. Does it hurt when I touch it?
No.
No? How about when I touch that
Don't
side?
touch that one like that. That hurts.
Well, that tells me I'm assessing. I'm checking.
Okay, I told you it hurt. Don't hit it.
All right, ma'am. It's okay. It's okay. Honey, it's going to be
No,
fine.
my name's not Honey.
No, his name's not Honey.
No, my name's Allie Mae.
Allie, okay, Allie Mae. I'm sorry to bother you about that. So any other problems I need to know about?
No.
No? Okay. Can you move your hands for me? It looks pretty good to me. Yeah. Your mask? That's just silly stuff. And I don't think you need to have that mask on at
No,
all.
I don't want to be sick. You got germs.
No, it's going to be fine. It'll be fine.
Everywhere.
Do you see a difference? Do you guys have a question on that? Hey, let me ask you a question, okay? Have you had someone like that? Have you ever been to the hospital? Don't be that person. Don't be that person, okay? We're here for you to understand what you need to do. We're here to make sure you know what you're doing, why you're doing it. She's there to make sure you take harder tests in the second year.
Bye, guys. Have fun.
Thank you. That was fun. Now that I'm in my office, let's switch over cameras again. Did that help? Just as an idea of what you're going to be doing. Again, we can sit in here and I can assess somebody for hours at a time because there are literally hundreds of different tests you can do on assessment and find out lots of interesting information about that patient. Questions that you can ask. I was just introducing it to you. So let's get into the slides. And again, I'm going to reaffirm, when you get to clinical, you will be going through this ad nauseum every day. You'll be doing head to toes. You'll be doing focused assessments to figure out what's going on. But head to toe is where you start, okay? It is not normal for me to assess without gloves on. We are in the lab and there are no gloves currently. So absolutely you put gloves on for everyone. Good question. Your slides should be almost identical to mine. There's a couple slides I removed, which you'll kind of see as we go through, but I've added some images more for flavor so you get an idea of what we're talking about. So, but the information is the same. Okay, can you all see my slides? Question, make sure you save all questions for the end, but just to answer your question, they're asking about undressed or making people uncomfortable. Let's start with you being able to actually do the assessment, and then we can teach you the verbal skills to go through that sort of situation. But for now, let's go through a health assessment, okay? All right, we have adult health assessment. I've given you an example of both good and bad. What is an assessment to you? Give me a couple answers. What do you think assessments are for? Identify, diagnostic exam, status of the patient, information gathering, overall status, current status, pre-evaluation, get a base. Get a base is very good. All of these are really good ones so far. Baseline. Overall idea, absolutely. Physical check of a complaint, as well as multiple other things. This is one of the biggest terms you'll want to remember is baseline. Okay, you want to obtain that baseline information. What you're trying to do is say, I have a patient, I'm going to go in there and see how they are currently. So if I don't see them for an hour or two and I come back and they're worse or getting better, I can tell the difference. Versus if I haven't seen them for 4 hours because of my team is busy, I go in there and they're not breathing. How long have they been not breathing? I don't know, I didn't get to them for 4 hours. Always put your eyes on your patients, okay? So let's go through this. This is the adult health assessment. This is what you will all become at some point, is this nice, tired nurse learning how to do your job, but you'll still be one. Okay, an assessment. These are just definitions of different types of assessments, just to kind of touch on them though. Your comprehensive assessment is everything. It's a head to toe. It includes general psychologic evaluations, your spiritual, socioeconomic, cultural, all things that, especially an inpatient, you will do. You will get more and more information about these patients. The history and physical exam, kind of like what I just did. We go a little bit further into disorders, asking, say, what kind of disorders do you have, or comorbidities, or do you have diabetes? Have you have a family history of hypertension, or questions that make sense to your patient, things that may make sense to the actual disorder you're dealing with at the time as well. Now, medical assessment is more disease and pathology. It's what the providers do. They go into there and say, okay, this is the information that I need to find about so I can figure out what's wrong with you so we can treat you. We are different as nurses. We want to be able to treat you, but we want to figure out what caused it. We want to make sure we can take care of you the best way we can. And to do that, we need to know what caused the situation, what we can do to help you get through that situation again, so it doesn't happen again. Maybe it's educating them on stopping smoking, or maybe it's educating them to talk about the fact that they had an MI because they eat fried food 4 times a day for the last 10 years. Going through, assessing, finding out what some of those causes are, and educating them, talking to them about it. And the physical examination. So these are 2 big terms you're going to need to know, subjective and objective. Subjective information or data is information the subject tells you, something you can't physically see or feel. They tell you they're in pain. They tell you that they're itching. I can't see the itching. Maybe I can see the redness or excoriation and the scratch marks on them, but I can't necessarily see the itching. That would be subjective. Whereas if I actually see redness on the skin, if I see an open wound, anything like that, that would be objective. I can objectively see that this is what it is. You need to know those, because as you start making these nursing diagnoses and you have to start writing down like what's supporting your choices, you'll need to say subjective information and objective information. So make sure you have those 2 separated. Again, subjective would be what the subject tells you. Objective is what you can see, what you can physically assess or hear. So why assess the patient? You guys already got a lot of this. Identifying your nursing diagnosis, baseline data, monitoring what's going on, and screen for other health problems. In the hospital setting, you'll be doing this. This is your job. This is something that you cannot divert to someone else. An LPN, now, I'm going to say this. I know we have LPNs and other people in this group, but per NCLEX standards, if you see my hands like this is your ivory tower, okay? The only person that can assess a patient is an RN. If you see a question asking about sending someone off and say, hey, I'll have the LPN or CNA assess or evaluate my patient, no, you can't do that. Only the RN is legally allowed to fully assess a patient, okay? They can get information and gather data, but they can't make the decision on that. Real world is slightly different, but again, we are going through the NCLEX. The reason you need to know this kind of stuff, though, is I'm going to give you a quick story. So I had a patient a few years back with students who we went in to assess her one morning, take a look at her, and she was breathing, but she had her mouth open, tongue out with a blue substance on her tongue. Couldn't wake her up very well. We shook her, barely woke up for medicines, and she still wouldn't stay awake when we talked to her. So we went and checked. The aide for that patient, I had just kind of mentioned it, and the aide said it was absolutely fine. That's how it is. I didn't feel comfortable with that because the patient was very somnolent or was very difficult to wake. So I went to the nurse for that patient, and this nurse had had this patient for 4 days. And the nurse said that's absolutely not correct. Went into the room. We assessed the patient and found out that she had been taking narcotics from home in between nursing visits. And that was just an actual capsule form of a narcotic that she had been taking, and she had passed out while taking it. She had so much in her system. So you need to know what your baseline is, and don't just trust what someone else says. Understand what you are looking at. Understand your patient, okay? Don't make an assessment or judgment based on what someone else is assessing. Okay, just as a quick heads up with this stuff, you've got your inpatient or comprehensive, also known as a head to toe. You go through everything step by step. You go through and say, okay, I'm going to start here. I'm going to work my way down. Do you have to do it my way? Absolutely not. As long as you do a head to toe. Some people do it by systems. They go system by system, but then you have to go to the head 6 times, literally, to make sure you get the right musculoskeletal and neuro assessments and make sure everything's there appropriately. But if that's how you learn everything, absolutely. Figure out what works for you, okay? Figure out what's bothering them with the inpatient assessment. ED, it's very focused. If you come in with short of breath, I'm going to assess your lungs. I'm not going to your toes. I'm not necessarily going to your head. I'm going to look and listen to your chest, to your lungs, and figure out what's bothering you. You have system specific. Again, this is just organ by organ. Your ongoing assessment, this is your daily life of a med-surg nurse. This is, you have your initial assessment. You'll go in there and constantly talk to your patient throughout the shift, reassess if there's any changes, see if things are getting better or worse. Is the antibiotics working? Do you see a fever reduction, or is it getting worse? And maybe you have to call the provider and say, hey, the medication may not be working. They're getting worse, not better on it. Again, assessment, figure out what your baseline is and figure out what the patient's doing while you're taking care of them. How do I do it? Systemic approach. Do it every time. The easiest way as a nursing student is to practice this. Practice, practice. You practice on your children, practice on your spouse, your parents, practice on your best friend. The big thing right now you have to worry about is that social distancing, so do people hopefully in the same household, but practice this and figure out what works for you. I had a huge document, or at least the book, when I was in nursing school, that I would literally flip it open and say, okay, I'm going to do a cardiac assessment on this patient right now because I'm having a hard time remembering how to do it. I'll flip that book open and I will read the book and assess the patient. Yes, it's going to take them a lot of time, but they signed up for it when they said you could go to nursing school. Just remember that. We use a head to toe, as I've already discussed on there. Looking at all this information, you do have to know your exam equipment, your A&P, your techniques are very, very important, because if you don't know how to assess appropriately, you're not going to find the information that you need. You need to be comfortable and confident, because a patient will pick up right away if you're a nurse and walk in there like, I don't remember what I'm doing. Or even if you don't say anything and you look confused, they're going to pick up on it quick. So practice this so you get good at it. And don't be afraid to ask. The difference between a good nurse and a bad nurse, a good nurse and a bad nurse, honestly, is one who asks questions. You're not going to remember every assessment. If I asked you to find out if someone's about to have a seizure and they're pregnant and you have no history in that other than that one time in nursing school that your professor mentioned the word clonus to you, you'd be like, what do I do with that? That's okay. There are other nurses around you. There are ways of looking up policies and videos to help you do that proper assessment if it's something you haven't done in a while. And that's okay to ask. If you ever feel like you know everything, leave the unit. You should never feel comfortable, because comfortable nurses are the ones that cause problems and can kill a patient, because they feel like they don't have to ask a question. They feel like they know everything. And when they do something inappropriate, well, I thought I knew how to do it. Don't be that nurse, okay? Keep learning. Always keep learning. When you retire, you'll never stop learning, but then your license will be retired. So you don't have to worry about it so much. How do I do it? Prepare for what you need to do. Figure out what you're going to assess. If you're going in there for a comprehensive assessment, make sure you know you've got time to go in there and say, okay, I've got to go through every system, all the way through to make sure that we're good. Give that patient privacy. Give them a blanket. We didn't have a blanket in here, so she didn't mention that, but we want to make sure, give them privacy, get the drapes closed, which is, these magical drapes that are soundproof. Make sure you keep everything closed and give as much privacy as possible. Maneuver the patient. I had that patient move a little bit, so I'm not going to have them lay flat. If I need to hear the back and actually auscultate or listen on the back, I need them to sit up if possible, so I can actually listen appropriately. If I want them to have a gown on, so I can open up and take a look at that skin on the back while I'm also assessing their lung sounds. Whenever possible, look your patient in the eye. Don't look, There are cultural deviations to that, which as we go into this, we'll discuss, and we go into other lectures, we'll discuss that. But for now, just think of this. You want to give them the respect. You want them to know that you're there for them and that you are listening to them. Table 22.1. Know this. Know your positions. Know your body positions. There's also an image or two on the actual content for this week. There's an image in the content section of it, so you can see all the different methods and different ways of body position. So you need to be able to know what those are. And there's a slight discussion, or excuse me, a slight description of that as well when you go in there, so you have an idea of why you would choose to put someone in that. This is your order for assessment. No matter what system you're on, you look at it, you touch it, you pound on it, and then you listen to it, okay? Inspection is looking. Palpation is touching. Percussion is actually, and you'll get more experience with it, but is actually tapping your finger or actually getting the sounds from the body. And auscultation is listening to what the body is doing, okay? Listening to lung sounds, listening to heart sounds, listening to what the bowels are doing. There's one exception to that, and you do need to recognize the difference between these. Again, inspection, palpation, percussion, auscultation. With the abdomen, if you did it in that order, you would get a high likelihood of false results. Because if you touch the belly doesn't like being touched. If the belly is touched, it tends to slow down or speed up, one or the other, and would be out of, and then the normal findings would be out then. So you want to look at the belly, you want to listen to the belly, and then you'll poke and prod, percuss, and palpate the belly. And again, that's why we want to make sure that you recognize that when you're doing this abdomen, it is different. So you've got inspection, palpation, percussion, auscultation all over the body. But when you actually do the abdominal, make sure you do inspection, auscultation, percussion, and palpation. That way the auscultation won't be wrong when you actually do that. When you walk in the door, that's when you assess. If you know any nurses, there's no way they can turn assessment off. When I walk in this door, I am literally looking at every student, every face. I am looking at to see, oops, so sorry about that. I'm looking at every face. I'm looking at everyone walking by. I can't turn off the ability to assess someone because you spend so much time in nursing school getting it down. It doesn't go away. Heck, if you decide one day to retire, you'll still be doing it. Even when you walk into Walmart, someone's walking with a slight gait, you're like, oh, I bet they have this, or I see this. You're going to do it. So you need to start practicing it. And when you walk into that patient's room, a lot of times you're going to be like, oh, they welcome you, they greet you, they talk to you, you talk with them. You literally are doing assessments while you're just chit-chatting with them. So you need to get good at that. You'll also find out when somebody looks wrong. If you were talking to somebody for 10 minutes, come back an hour later, come back and they are just not breathing, or hopefully you can catch them not breathing, but if they're just not responding as they were, they've turned yellow or they turned gray, you'll be able to quickly tell from the door that something's different, something's changed, and you need to figure out what's happening. Palpation, touch, temperature, skin temperature, moisture, abnormalities, areas of tenderness overall. If you can push down and someone says, oh, it hurts there, but it didn't when you didn't do that, that's information. You're not there to figure out exactly what the cause is. You may have ideas for that, but you're there is to find those things, find the data. Your fingers can find a lot of information just by light touch, heat, temperature, you get your general moisture, abnormal, everything that's on there. You can find that with just your fingertips. But when we deal with more, if you want like an actual temperature to figure out if it's really warm or not, or cool, use the back of your hand or the dorsum. It's actually more sensitive to it. You can't say fever because you don't have an actual reading on it, but you can say if this is much cooler or much warmer than you feel it should be normally. When dealing with pulses, always use the tips of your fingers. That's the most sensitive to be able to feel. And then, of course, you grasp with your finger and thumbs. When you're palpating, if you saw when I was pushing on her belly, what I did was I went like this and put it on her belly, and then I did a second hand. What I'm doing is you can push slight pressure on that belly or anywhere that I'm palpating. And that should give you a little bit of information on their feel, if you feel any nodules or if they have any pain with it. And then especially on the abdomen, you may have to go deeper and figure out if there's pain that's deeper to it. And if it's a larger patient, a smaller patient you can do with one hand and kind of push harder. A larger patient, you would have to do two hands to push in just to be able to make sure you can get by any adipose or anything large that's in the way. And people will respond to what you're doing. As you're touching them, if it hurts, they're going to tell you it hurts. If you yell at a patient, telling them to wake up because you're worried about them. Remember that patient I was telling you about earlier who wasn't responding very well, and I give them verbal stimuli, trying to raise my voice, like, hey, wake up, are you there? Can I help? What's going on? If I have to raise my voice, they should wake up to that if they're asleep. If they're not waking up to very quiet, like, hey, can I wake you up? I have a question for you. You should be able to talk to them and change that stimuli. If not, you have to go further because sometimes there's something wrong and verbal stimuli or being talking loudly will not work. Percussion. These are this is more something that, well, as a nurse, you need to know how to do this. You can find some very interesting information in it, but this takes practice. You do absolutely have to know what percussion is and how to do it. What it is you actually have to bend your finger and tap it on the structures of the body with your wrist and not your hand. It takes a little bit of practice, and you will get it in lab and clinical to get an idea of how to actually percuss. But you need to understand what you're listening for. You're listening for different sounds like resonant or dull, tympanic. There's all these words in your text to go through to make sure you understand what percussion is. And we want to make sure that you have an idea. So make sure you listen to percussion, okay? You want to be able to hear what that is. This takes practice and a lot of experience to really master. So make sure that you at least start now. Get an idea of what you're looking for. Auscultation. It's hearing, okay? You can auscultate with or without a stethoscope. Most of the time you see, oh, I'm auscultating with the stethoscope. Absolutely. But when I'm talking to you, technically I'm auscultating as well. I'm listening. I hear things, okay? Now, most of the time, like I said, you will have a stethoscope with you. You're going to listen to the heart, you're going to listen to the lungs, you're going to listen to the bowels, and listen for something that's odd. You can actually listen to certain areas on the abdomen and hear like your descending aorta if there's a problem. But you have a stethoscope. With the stethoscope, you have two sides to it. You have a diaphragm and a bowel. Your diaphragm is more high-pitched sounds like your heart and lung sounds. Bell, if you can't hear anything, it's really low, it's kind of here. Switch over to the bell, which is the smaller part. You put pressure on it, and then you create a seal by doing that with the stethoscope you see there. It gives you a nice seal and easier to hear what's going on with that. You may even have to put a little more pressure on the bell, depending on what you're doing. And again, introduction to tools. Introduction. As we go into systems, it'll, make more sense. Olfaction. It's not an order, you're just going to smell, okay? While you're doing this, you have alcohol, DKA, UTIs, wound assessments. There is a lot of different things. You can smell wounds, GI bleeds. Anybody with any sort of experience will know that if there's a GI bleed or something called C. diff on the floor, you can smell it from the elevators and you're 100 yards away. And if you are any sort of sensitive to any smell, I'll get you over that real quick this semester. Because you will smell that, because those come in a lot, especially as we get into winter. But make sure, you may not know what the smell is, but if you can explain it, or at least write it down in your assessment, and while I'm taking care of this patient, I smell sweet, or I smell sour, or I smell, blood or irony smell. Be able to describe what you're smelling. Okay, I'm going to kind of skip over these for right now, just because I want to see if we can get through them. If we have time at the end, I will go back through them. But the answers are on here, but the answer on this one is B, palpation. Age groups. I have mentioned before, we are only studying adults and geriatrics in this course. However, this book mentions a few things, and I wanted to make sure we touch on just a few things with this. How you assess someone changes based on age. What do you think the easiest way to assess an infant would be? Held? Held by who? Yes, absolutely. In the parents' arms, it tends to help. Parents' arms, because they're not going to necessarily want to be, right next to you. They're comfortable in their parents' arms, usually mom, but again, it can be dad, doesn't matter, as long as it's in a parent's arm or somebody, a loved one's arms. That helps you with that assessment. Toddlers, again, tend to sit on their laps. They're fearful of certain things. They're fearful of you unless they've been with you constantly. And they also don't like invasive things, okay? So if you notice down there, it says oral cavity assessment, inner ear assessment. That's all done last. Because if you have children or have seen a child actually assessed, what will happen is they'll be walking around, you get a lot of cool information while they're just, playing around with everything. And then when it's time for that mouth and ear, it's the last thing they do, because once again, they have to be held. You quickly go to the mouth, look, quickly go to the ear and look, make sure everything's okay. And then they're probably screaming at you because you've irritated them. Something's invasive and it bothers them. They're not used to it. So again, when you get to pediatrics, you'll get more experience with that, but that's more of an introduction. And preschoolers, any tool can be shown to them that's safe. Anything that you want to do. If I want to show them my pen light, which I do all the time for children, they love this thing. Sometimes I have to hand it over to them, which is why I carry a second one so I can actually do my job. If I have to do, they have those little hammers that you can check reflexes with. I can hand it over and like, oh, look at that. Make sure they're not going to hurt themselves, but kind of show them, explain things a little bit to them, what you're going to do with it, and then it'll help them be a little more comfortable. School-age kids, when we get into that, ask them life questions. They're at that age where they're starting to recognize that they're individuals of some kind. Keep them interested. Tell them that you're interested. Ask them questions about their life. How are they doing? How are they doing in school? Do they feel, how do they feel overall? Help them by talking to them and making them think that you're very interested in what they have to say, because they will give you information if they feel that way. And again, show them what you're going to be using and why. Adolescents are self-conscious. Absolutely. If you have anybody that's a teenager or have ever been a teenager, we're self-conscious at that point. We want to know that we are individuals and that we have freedoms and rights and that we have certain viewpoints that we want everybody to know about. But for assessment, they may want to be alone. They may not want their parents in the room. They may want specifically to just talk to the nurse. It's not necessarily a bad thing, but you always want to try and make sure that that happens. You want to make sure if you can take care of that patient, just be able to assess them and they're more comfortable without the parent in the room. Absolutely. Let's go ahead and do this and ask the parent to step out of the room. And as we get into the adults, we got young and middle age. There's usually no problems. This is the ones that we normally assess. These are the ones that we come in and say, tell me what your issue is. They usually have a problem and they want it fixed and they know we have to get the information necessary to do it. Not always. You'll always tend to have somebody every shift who's like, well, just give me the information or give me the medication. I don't need you to assess me, just treat it. I need to still find out what I need to treat or take care of you with or what medications to give you because I need to assess you and ask you questions before I can give it to you. So always make sure they understand what you're doing and why. Age groups, older adults. So this is more just kind of a mnemonic. And as you get into acronyms and mnemonics, you're going to have hundreds of these things in nursing school. These are just things to kind of help you remember certain important things. So the older adults have a spiced up life, spices. So they have these kind of problems necessary that require some sort of help. Sleep problems, eating or drinking problems, incontinence and confusion, fall risks, skin breakdown, all things that are very common as they get older. So they're not necessarily going to happen, but they're common in the older adults. So we watch for it and we help where we can, find out information, and we can educate them. Hey, it's not necessarily something that is just for you. It happens in older sometimes, and now we're going to take care of you. We're going to make sure the provider knows so we can help you with these problems. So, assessment. General survey, overall impression, and quick. Look at your patient, okay? What do they look like? Are they dressed appropriately? Do they seem sad? Do they seem angry? Do they seem happy and laughing? Are they texting on a phone? Are they breathing 40 times a minute and they're bent over and their face is all white? What does your patient look like, okay? For speech, as you start talking to them, are they inappropriate or illogical? If they look at you and say, Taco Bear water truck. I just asked you your name and date of birth, and you just yelled Taco Bear water truck at me. Okay, that's something to write down. That's a finding. Okay, as you get into psych, as you get into that, you'll get more information about what some of that is. But again, recognize that maybe something, if you can find that somebody is saying something inappropriate, again, not all things are inappropriate, but talk to your patient. Difficulty speaking or dysarthria, sounding words, having a hard time, like they're just talking to you, but they're like having a hard time remembering something, or they're trying to say like their name, but they can't say it very well. Again, dysarthria, having a difficult time saying things. Rapid speech. All I'm going to say is rap God. I mean, that you have patients that try and talk that fast. Again, you'll get into psych and you'll go through that. If you haven't heard that song, don't worry about it. Just recognize that there's people who talk very fast with certain disorders, or they're so worried about somebody that they're like, oh my gosh, my son's in here and they're in this room, there's going on with this, their leg broke, they were in a car accident, I heard this, I'm his mom. I was like, who are you here to see? You need to be able to assess that, see what's going on. Hoarseness, difficult time speaking. It's that raspy voice, the slow speech, and then of course you got your vocab and sentence structure. Sometimes it's more of an issue, like maybe they don't speak English very well, which is something you'd have to catch on to quickly, because if you're taking care of somebody and they don't understand your instructions, you need to make sure that they have an interpreter. So if they say, you know, I am hurt, you, pain, fix, you may pick up quickly that they don't speak English very well. Or if something's wrong, like maybe they had a head injury and things are very slow, or the words don't come out the way they should, you can pick up on that. Dress, grooming, hygiene, objective information. Are they dressed like, you know, my patient right here or these other patients out on the yard? What do they look like? Do they have a tutu on with shorts and combat boots? I'm taking care of patients like that. You can still ask them questions. Maybe they have the best historians, though. They know what's wrong with them, what's happening, but they choose to wear this. Still, note it. What's their mental state like? Again, can be either objective or subjective if they tell you how they're feeling or what you're getting from information. Vital signs. What do you think vital signs is, objective or subjective? Objective. Absolutely. Objective, because you're measuring it. You have a measuring device and you're measuring it. So it's objective data. Absolutely. And then, of course, height and weight being objective. Now, can weight be subjective? Yes, Jane, except for pain level. Weight can absolutely be subjective. If you ask them what the weight is and they tell you and you don't measure it, it's now subjective data. So you'd have to separate that. Absolutely. The integumentary system, skin, hair, nails. So we're looking at the entire body, head to toe. So we need to take a look at that. That's why we like them in a gown. If I'm going to listen to their heart and lungs, while I'm doing it, I'm looking at their skin. I look at their feet, I'm looking at their legs to make sure I don't see any, what if I see anything that's abnormal to it. Do I see any moles, bruising? Do I see any bleeding? Do I see any bleeding under the skin? Excuse me. Do I see any changes? You've got pallor there, so that's more of that pale, and that deals with decreased blood flow or circulation issues usually. Your cyanosis is more of a hypoxic issue or low oxygen content, makes it more of a blue. Jaundice, the yellowing of the skin. Flushing, which is more of an increased blood flow to that area, so it makes it more red, looks more like a burn. Ecchymosis is more bruising. It's your term for bruising. Petechiae is leaking of blood out of the capillaries, so you tend to see these little like spider veins kind of showing into there. And then your modeling is more of a plastic look, end of life or cold situation when you have that. Your cafe au lait spots are up there. They're just light brown birthmarks that occur anywhere on the body. It's just a term that you'll have to know as you get into that. All right, assess the temperature, moisture, texture, turgor. Okay, so we've talked about temperature, talked about moisture, the texture, whatever you feel. Is it scaly? Is it rough? Is it smooth? What did you feel on there? Turgor. So turgor deals with what? Does anybody know? Hydration, fluid, elasticity. Yes, deals with the amount of fluid. Also, it can be based on age as well, but deals with the amount of fluid, tenting. So if I have somebody who's dehydrated and they're younger and I pull up their skin, what would more likely happen is I will see that skin stay up and slowly drop back. That tells me that they have, decreased hydration. They may be dehydrated with it. Now, edema deals, and you can see that the image down there, that's too much fluid, okay? You do need to know the stages of edema, and they are in your book 2, your lab book, which you should go through. I believe the table is 22.3, just so you know. But you do need to know that because you'll have to be able to assess that quickly if you find that. It's not uncommon to find that in this area, especially East Tennessee. Many of you may have heard of ABCDE. Why common in East Tennessee? East Tennessee is one of the largest areas for things like congestive heart failure. So that's why it's common. Integumentary system. So we've got our lesions. You may have heard of ABCDE before. This is more looking at moles. So when looking at moles, we're trying to figure out if something's different or wrong about it. It's not bad to have a mole. It's bad if moles change because we're worried about cancer. So you're looking at things like asymmetry. The mole should be a circle. It should match on both sides. If it's not, it's asymmetrical, it's something you have to worry about, and you report that. Border irregularity. Is it a circle or does it have like this, like clouds? Does it break the borders? The color is different. Do you have reds and blues and browns in it? Like this one has light browns and dark browns and almost blacks in it. Diameter greater than 0.5 centimeters. A pencil eraser. If it's bigger than a pencil eraser, something you worry about. And then the other E is called evolution or elevation. Your book says both. If it's larger than the skin surface, if it bulges up. If you have any of these things, you'd want to make sure you tell the provider about it, so they have a chance to actually go and assess that as well. All right, the hair. As I said, skin, hair, nails. When we talk about hair, we're looking at color, texture, distribution. What color was the hair of my patient that I brought in today? Gray, dark brown, brown, gray. Okay, kind of both. It was a brown gray with that, okay? You need to be able to pull that stuff out of it. You know, if when you walk in there, you will just get information from that patient. And your nursing instructors, as you go through, may be like, when you go to clinical, like when you finish your assessment, what side was the IV in? What color was their hair? Where was that bleed? You know, what did it look like? What did the wound look like? You need to be able to pick that information up so you can remember your patient. So texture, color, distribution, texture, color, all this is extremely important for different disorders, because as you get into things like hormones, you need to recognize that these can all change them. Does anybody know the difference between alopecia and hirsutism? That's okay. Close. Hair loss versus excess hair is very close. Alopecia is hair loss. Yes, alopecia is hair loss. Too much, you're very close. Too much hair growth is actually called hyperhidration. So we're getting into it. So let me make sure. So you have the idea. Alopecia is hair loss in patches that can become large. Hirsutism is male pattern hair growth on women specifically. So this would be on the chest, the face, the back. So alopecia is patches of hair loss versus hirsutism, which is excess hair growth and male pattern hair growth specifically on chest, face, and back. It can be genetic. It can be other situations as well. The nails. Whenever I went to that patient, I looked at it and I kind of squeezed the nail and looked for something called a cap refill. If you grab your finger and squeeze it, it should turn white and then quickly turn back to red with under 3 seconds. If that's there, then you've got it. You're good. You watch for change. It shows proper blood flow to that area when you can have that under 3 seconds. If you find somebody with over 3 seconds and their hands are really, really cold, maybe warm them up, hold on to their hands for a second, and see if that cap refill comes back. What does their nails look like? Are they blue? Are they white when you see them? Do they have a different nail shape? If you can see down here, that image I put there, there is a clubbed finger, set of fingers on the right. On that window, you can see right there where it points out window in the left image. That is normal. If you do that to yourself and you don't have clubbing, you should see a little gap, and you should be able to see through it. If you don't, and you have that kind of clubbed finger there, you're looking at a chronic hypoxic issue, someone with COPD and long-term smoking. Do you see white spots or yellowing nails? What do you see? Take a look at the nails and describe it. We'll take a break and just let me get through these next 3 slides and we'll take a break. The skull. Look at the head. What does it look like? Is it large? Is there throbbing in the head that you can visually see? Is it small? Is there fluid on the head? Can you actually see like a little bit of movement into it? The jaw. There is the temporomandibular joint. If there's cracking there, you can put your hands and your fingers right to that joint, and if they move it, which a lot of people do have, you'll feel like a cracking sound, which would be called TMJ. Looking at the eyes. So figure 22.3 is something you need to know. So make sure you have an idea of what we're looking at. But we're looking at 6 cardinal fields of vision, which is where you saw me bring my fingers or my pen down in different methods so I can watch for eyes move in an equal pattern. I'm skipping over Perler for a second. Color vision. Can they actually see what you're looking at? What color is something? Cataracts. Do you see grays behind the eyes? Are they cross-eyed, lazy-eyed? When you're assessing these patients, if you can't remember strabismus, amblyopia, things like that, it's okay to say that they're in the chart. They have a eye deviated, or they have a
what patient states is a lazy eye on one side. It's okay, because you're not memorizing these terms specifically all the time. You may not see it all the time. Now for Perla, you need to know what this stands for. You need to know how to assess it. Most people know how to assess the first 5 letters. Pupils are equal. So if I look at one, it's the same size as the other. They're round. Both of them are round, which you can have differences. They both react to light. So in a dark room, if I put the pupils will normally be enlarged. If I put a light over one, both of them kind of constrict. You'd expect that. And the last one is called accommodation. Do not write Perla unless you can say Perla or that A. Accommodation is specifically, you've seen people kind of pull their finger in towards your nose. What's happening is your eye is actually constricting and then opening back up. When you pull back, that is accommodation if both sides are doing it equally. So you need to know what that means, because if you have a stroke patient and say they have Perla and they actually don't because you forgot what the A stood for and just assumed, that's on you. 2 more slides, we'll take a break. The ears. There's a lot of good information as we get to the head, but the ears are really interesting. The ears help with balance. The inner ear specifically helps with balance. It helps with sound. What is the pinna normally leveled with? The pinna of the ear, the top of it specifically. The outer canthus or lateral canthus of the eye, not the eyebrow, the outer canthus of the eye specifically. So if you put your finger straight across, it should go there. Does anyone know if a child is born with a pinna that's lower or higher than that, what organ you'd have to assess for? It's okay. It's a very interesting one. I want to make sure you knew this. If you have somebody whose pinna is slightly off, they need to assess their kidneys, because in utero, the kidneys and the ear form at the same time. So if something's wrong with the ear, you're worried about the kidney. Something interesting in peds. So you've got otitis externa, which is that lining inside before the membrane. You have an infection of the inside of the ear. Otitis media, which is the actual membrane of the ear, inside of the ear for an infection. Cerumen, you've got your earwax. This tells you about tympanic membrane, what it should look like. If it's any different than that, you would note it. If it's red or if it's, you have purulent material on it. Oh, let me ask you this. Does anybody know, well, what would you call something if you saw like an infection and you saw a pus come out of it? Do you know how to actually chart that? Drainage, well, okay, so purulent is absolute. It is drainage, but you need to describe it. Purulent material. Do not say that it's pussy. Do not chart that it's pussy. Do not chart that it's pussy. If you want to know why, go to your notes and write down the word pussy and see what it spells. Okay. It's purulent. Okay, Weber and Rhine test. This is more dealing with your hearing. It's actually a tuning fork where the Weber is up here on top of your head, which makes sure that hearing goes to both sides equally, and Rhine goes behind and checks for bone conduction. It's a tool that you will see in lab to kind of get an idea of how it works. But just remember, Weber and Rhine deals with hearing. And then your Romberg test. My patient is not here anymore, but the Romberg test, when you do it, requires that patient to stand up. Can you guys see me still? I don't have that video up. Can you see me all right? Okay. The Romberg test, you have the patient stand, you have them put their hands to their side, and you have them close their eyes. And you have them raise their arms, and you have them stay there. If they begin to wobble, you need to be right there to make sure they don't fall. But if they begin to wobble, you know that they don't pass the Romberg test. There may be a problem with their ears because of their balance. Okay. Last one, then break. The nose. We use a pen light and look up there. Okay? They should be able to breathe out both sides. But do you see any blood? Do you see any dry blood? Any discoloration? Any masses? A deviation of the septum or a change? Is it closed on one side? Vertigo, absolutely. Is it occluded? The mouth, teeth and gums. Look at them. We, a lot of times in the ER, again, background in ER, we kind of let things be when someone says it's dental pain because we can't do much in the ER for dental pain besides numb it and say go to the dentist. Well, I'm going to tell you right now, we had a patient come in who was sitting there in the chairs, is what we call it, which is where the non-acute individuals are. They just came in for help. And they said that they had teeth pain, which is where we put them on it. Well, we went over there. Nobody assessed this patient. They were just kind of like put to the side. I went over there and checked the patient, and he said, yeah, my teeth are killing me, specifically right in front of my front teeth. And I said, huh. So I lifted his gums up, and he had a huge abscess formed that was a big old whitehead right there on there. That's not dentist, that's us. That is a IND situation. And we got to actually clean up and, for lack of a better term, pop that thing. We IND'd it to clean everything up, and the patient felt much better without needing to go to the dentist for it. Assess your patient and figure out what's going on. Don't just put things to the side. Don't assume what they're saying is always right, because you may find something else. Also have them stick their tongue out. You know, my patient back there was sticking her tongue out when I looked at it, and it stayed on one side. If they stick their tongue out and it deviates to one side or the other, I'm worried about some sort of neurologic problems. What does the tongue look like? Is it red? Is it pale? Is there white on it? Is it furry? I need to know. And then what is their head like? Are they locked like this the whole time they're talking to you? Do they have their head kind of stuck like this? And when you ask them, they're like, no, this is how I say I can't move my neck. Information. And the thyroid, I didn't do that on this patient, but the thyroid you actually assess here. You need to practice to be able to do that. Yes, furry. You need to practice to be able to do that, but what you'll do is you kind of push it, you can feel the thyroid. If there's masses, it's really easy to see or feel when you do it. Okay, let's take a break. How about, let me turn off the screen share for just a second. We'll come back at 9:45, so 10 minutes. Okay, sorry about that quick break, but here we go. Let me do a quick screen share and we'll get moving. All right, breast and axilla. We will be doing, you will have to know how to educate someone how to do this, especially on their own, as well as you'll also know how to do this. But does anybody know why we assess the armpit with a breast exam? You're checking lymph nodes, yes. There's one more thing though. Ginger, it used to be thought that most breast cancers begin there. So yes, they're checking lymph nodes. However, there's something called the tail of Spence, which is actually breast tissue that expands into the axilla. It's something to know that cancer can start here. So part of that is to tell them, make sure they go and check that. The tail of Spence, S-P-E-N-C-E. But you also would check lymph nodes as well for that. But know that there's actually breast tissue up there as well. All right, with your chest and lungs, be systematic. You can kind of go in your order, how you want to do stuff, but a lot of times for these systems, it helps a lot to just go with your normal order, okay? So know your landmarks. You can kind of see them. I put them on here, but you have your sternum. You had your mid-clavicular lines, which I put in here to make sure you understand what I mean by mid-clavicular line, which is on the top image. You also have your ribs. So the easiest way to remember how you assess this when you're talking about the heart, it's called 2, 2, 3, 4, 5, okay? Second intercostal space, right sternal border. Second intercostal space, left sternal border. Third intercostal space, left sternal border. Fourth intercostal space, left sternal border. And fifth intercostal space, mid-clavicular line. That right there, and we'll have more slides kind of explain it to you, but that right there is how you remember your landmarks and how to remember the order that you assess your heart, okay? When looking at the chest, lungs in general, one of the easiest ways to kind of check respirations is if they're bathing. That tends to help because you'll be assisting with bathing as well. It's really good time to check and see what happens with their body. You can look at their skin, you can look at respirations because they tend to increase. when you're actually bathing to get more relaxed. And then look and see how they're sitting with that. You know, are they sitting comfortably? Are they laying flat? Are they straight up? Are they kind of sitting straight up and with the rapid breaths? Are they leaning forward? You know, how is their lungs actually going to be responding to their body position? So they may have to breathe more rapidly or slower. These are the different breath sounds. I've put a link down here that you can click to. It's just about a minute or two long, but it lets you just hear what the different breath sounds sound like. And the terms of the sounds should make sense. The tracheal breath sounds happen in the trachea. The bronchial breath sounds happen in the bronchioles. Should just make sense with that. Okay, the cardiovascular system. It's about the heart itself is about the size of a clenched fist. You've got pulmonary and you've got systemic circulation. The arterial system carries blood away from the heart, and venous system carries blood towards the heart. Your coronary circulation feeds the heart with oxygenated blood and takes the old blood away. And then you've got your central arteries, such as aorta, carotids, descending aorta, etc. Image of a heart, kind of giving you an idea. Sure, a few of you have probably seen an image like this. More of the cardiovascular system kind of explaining where things are. All right. The heart is at an angle of the left side of the chest. Yeah, we got it. It's the heart, okay? We know where it is. You can see on the image down below where the heart actually lays. So you can kind of see when I was talking, let me see, I can't get that image up. Can you guys see my mouse? Yes, okay, good. So you can kind of see when I said second intercostal space, right sternal border, boom, you're looking at the top of the heart. Left sternal border, boom, looking here. Third, fourth, and then we go to fifth, and you can get, about right here, you can get to the apex doing it right there. So that's what I mean by 2, 2, 3, 4, 5. That's what we're assessing, right over the heart. I hope that helps you visualize that more than just memorizing numbers. We talked about systole and diastole before. Remember, systole is more that squeeze of the heart. Diastole is the resting set of the heart. And point of maximal impulse. This right here is pulsation over the fifth intercostal space, midclavicular line, which is why, again, we do that. That is absolutely normal to feel at PMI. If it's moved, sometimes you actually may see this slightly more may feel it over here more, or even over closer to the axilla. That's not normal. More than likely, they may have something like COPD or congestive heart failure that has caused their heart to enlarge. So to find that, you'd actually have to assess it. So you may not feel that PMI in the place you think it is. So you may have to move over and then find it. And then you palpate for vibrations, okay? It can be felt in a lot larger arteries, and it's very easy to palpate if it's present, usually with a heart murmur. It's just an abnormality of the heart for now. Look at that, 2, 2, 3, 4, 5. So second, third spot, fourth, and fifth, okay? So you have the second, up here you have the aortic area, second intercostal space, right sternal border. You have the pulmonic, second intercostal space, left sternal border. Erb's point, which is that third, which lets you check a couple different areas of the heart. Fourth space, which is tricuspid. And then that fifth, which is midclavicular, which is the mitral or apical area. You need to know these in order. There's a lot of different mnemonics for this. I'm going to give you a simple one, like Aunt Pam enjoys taking medicines. Kind of think through APETM to help you with that. There's also ape to man. It's up to you and how you want to do it. When you're looking at this kind of stuff and listening, listen for anything that's not lub-dub. If you haven't heard heart sounds yet, you need to start listening because you should hear lub-dub, lub-dub. If you hear anything else like lub-dub whoosh or whoosh lub dub, that's abnormal. Do you know what it is? Nope. Are you a cardiac provider? Nope. You may get, if you become a cardiac nurse, you may recognize some of these, but recognize what's normal and be able to describe if it's not. That's what you need to be able to find. You may hear clicking. You may hear whooshing. Murmurs, just additional sounds, and that's usually because something's not flowing in the right way or something's blocking it, so it becomes more turbulent. You can go to that link right there. There's a YouTube. It just kind of shows you some examples of different murmurs. I actually added this link last night because I forgot to put it in. So practicalclinicalskills.com. If you go to that website, you can use it for heart sounds, EKGs, lung sounds. The easiest way to use it is to simply put the bell of your stethoscope against your speakers on your computer, turn it all the way down to like 1 to, if you have a range of 1 to 100, put it down to like 5, maybe 10, so you can barely hear it, and put your stethoscope over it and start listening. That's what it'll be like to actually listen over somebody's chest. Another image to get you an idea. And just so you know, as things get harder to hear, even that quiet, you may have to switch, like I said, to the bell of the stethoscope, because that bell lets you hear things a lot quieter. We've gone through the artery system. It carries blood away from the heart. Remember when I did that assessment, I did not palpate the carotids both simultaneously, okay? What do you guys, does anybody know what would happen if I were to actually rub both arteries at the same time? You could cut a clot, yep, blocking blood flow to the brain, pass out, active receptors, yep, activating receptors, they're called baroreceptors. Patient's gonna pass out, they're gonna have a vagal response and just like their blood pressure is gonna drop. And again, you can have them deprived of oxygen in their brain as well. So they're more likely to pass out. With emergencies, you may see atrial tachycardia or atrial flutter, which when you get to cardiac, you'll need to know those right now, don't worry about it. You may see it in that to kind of slow the heart down. But again, if there's a clot there, you risk of poking it and making it angry and leaving and causing a stroke. Now, you may hear a bruit. So we talked about the thrill where you can kind of feel that pulsation. The bruit is what you'd hear, like a whoosh, whoosh, whoosh. When you listen to the carotid, you should, if you have the patient actually hold their breath, you shouldn't hear anything besides, I mean, if you have them hold their breath, you won't even hear anything. There's nothing there to hear. If you hear a turbulent, like whoosh, whoosh, that's very rhythmic, you're worried about some sort of blockage there. So you'll have to if you do hear something, then you very lightly palpate that for a thrill. Don't push it too hard because you will feel it if it's there. You've got your veins, carry blood to the heart. Jugular veins, kind of going through the anatomy and physiology of it. If you're looking at heart failure, you can have something called JVD. If the patient's kind of sitting at 30 to 45 degree angle at semi-Fowler's, you can kind of see like this increase in fluid to the right side of their neck, and it could be throbbing as well. And that would be JVD, and that would be a high likelihood of congestive heart failure at that point. And that's just because blood is backing up trying to get through to the heart. With the peripheral vessels, this is where we check blood pressures. It's peripheral. You have the peripheral pulses. You can check for perfusion. And then there's varicose veins. Remember, the veins bring fluid back, but there's no muscles really squeezing them. It's more valves and your own muscles moving things up, unlike the arteries. If there's too much pressure constantly, walking a lot, standing, constant running, working 12-hour shifts in the hospital without sitting, you have a higher risk of varicose veins, which are tortured vessels, which kind of enlarge, and it can become a big problem because you can have clots, etc. The abdomen. The abdomen needs to be broken up into 4. You may see things in other textbooks that talk about the 6, which are still useful, but this is what you're going to start with, is the 4-quadrant methods. You start at the xiphoid process, go down, and then you go from left to right at the umbilicus, creating 4 quadrants, okay? Remember what we said. We look at it, and then we listen to this. This is the change, okay? You inspect it, and then auscultate, okay? You want to listen to everything that's going on in there. What position do you think would be best to actually listen to the abdomen? I see supine, I saw prone, Semi-Fowler's. You can listen to it in Fowler's. The answer is the best position would be supine. Flatten their back. Okay? That would be the best time. Supine knee flex would be best for the patient if they have abdominal pain. But supine is the absolute best for the patient to actually listen and be able to do all your assessments on an abdomen. And when we're assessing somebody that's painful, especially on this area, you go to the opposite area. So if they say their left upper quadrant's in pain, start on the right lower quadrant, work to the right upper, go to the left lower. Don't touch the left upper quadrant until you've assessed everywhere that's not hurting, to make sure that, you know, when you push down, maybe there is pain there they don't recognize because they're more focused on the left upper. Always start with that painful area last. End with the painful area. Bowel sounds. Okay, we're going to still go through everything on that order. My personal way of doing bowel sounds is I always start where the small intestine connects to the large intestine and then I always follow the stool at that point, all the way to the sigmoid colon. That gives me a method, that gives me a constant method of going in case I find something, or if I don't hear something, I can see what happens past that. But again, if you find a way that's better, you can go ahead and do that, or works better for you. Now, bowel sounds have all these different things. You may hear the word borborygmus. That's just a fun, fancy word for bowel sounds. It can be high-pitched. It can be regular. If there's an NG tube, which if you don't know what an NG tube, it's just a tube that goes from your nose to your stomach. NG means nasogastric. And then it kind of sucks everything out of there. And it constantly has a vacuum in there, which can be loud. So just make sure if you're going to abscess an abdomen, just shut that NG tube off before you do it. So that way you don't hear like a whoo, like a vacuuming sound, or you're going to get a really weird assessment finding. Now, something big to know. This absent here, not heard after listening. If you go into an abdomen and assess it, and you don't hear anything in a quadrant for 5 minutes, butt pucker, okay? Something's wrong. But you need to do it 3 more times. You have to do the left upper quadrant for 5 minutes, right upper quadrant for 5 minutes, left lower quadrant for 5 minutes, and right lower quadrant for 5 minutes. It will take you 20 minutes to fully assess an absent sounding abdomen, absent bowel sound abdomen correctly. Because if you sit there and go for 30 seconds and don't hear anything, that's not it. Because the thing is with an abdomen, your bowel sounds, the normal range is like 8 to 12, maybe a minute, not often. And sometimes, and that's on average, sometimes it's 2 times. Sometimes it's 8. Sometimes it's 15, depending if you just had a big meal or not. But know that that's why we have you hold for 5 minutes a quadrant to make sure there is no sounds, okay? Hypoactive, common, very common after surgery, and hyperactive is loud. This is diarrhea. If you ever, as a nursing student, you ever get diarrhea or have someone in your house that has diarrhea, take your stethoscope and go right to that sigmoid colon. You will hear the coolest sound of like tin cans fighting each other inside of there. It's like, beep, 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 beep. It's really cool. So that's a really good sound to hear if you haven't heard it yet. Also with this, see that's hypoactive, hyperactive, it's your job to know when that's normal. So somebody just had surgery, you would expect, on their abdomen, you would expect a slightly hypoactive bowel. If somebody's taking narcotics, you would expect them to have a slower bowel because the medicine's irritating it. Or if somebody's having diarrhea, you'd expect that to hear that rush. And then I also put those major arteries there, something to worry about if there's an occlusion or you hear something odd, you can assess this. Somebody says there's a problem with blood flow to the left renal artery or to the left kidney, you can assess that left renal artery by just going to that specific spot. All right, musculoskeletal. Where'd it go? There it is. Bones, muscles, and joints. Lots of range of motion. We talked about active and passive yesterday. I believe you and Dr. Belknap did. But remember, active is if the client moves something, passive is if you move the client. You just need to know the difference. Look at the posture of your patient. Are they able to move? Are they dragging a foot behind them? Are they guarding an arm where they can't move, or guarding fingers and they refuse to move it because it feels like they can't move, or they're in a lot of pain? Is there clicking in the joints when they move? Do you touch their knee and it feels like when they move that knee, it's clicking everywhere? Neurologic? We're looking at reflexes and nerves in general. There's lots of different things you have to worry about with peds, which you'll talk about in peds. But the problem with older adults in the neurologic system is they tend to slow down. Why is it a problem that the neurologic system begins to slow down in older adults? Okay, dementia, now that's a little something else, but it could be due to dementia, but just the neurologic system in general. Falls, lose focus, slow response times, reaction times. Yes, absolutely. If there is a threat to you, you tend to react rapidly to it. They tend to react slower to it. If they begin feeling like they're going to fall, they may not be able to react as rapidly as someone who's younger may be able to. And then you got the Glasgow Coma scale. When you get to neuro, that is its own thing. There's a scale from 3 to 15. It looks at eye, verbal, and motor responses. The big thing on something interesting, I should say, on the Glasgow Coma scale is it's a range from 3 to 15, not 0 to 15. So technically a toaster who has no eye movement, is nonverbal, and not responding, no motor response, has a score of 3. So. Neurologics, okay? Orientation and mental status. Are they here? Where are you right now? What are you doing here today? What am I doing? What are you doing? And what can I do to help you? Be specific, okay? If they're having a hard time remember what month it is, that happens. Don't say that I have orientation problems because I forgot that today was the 1st and not the 31st. Or if I say it's the 24th and it's the 12th, like, actually it's this day. Oh, yeah. Don't do it necessarily on dates or anything. Now, if they say it's 1945, okay, now we've got a little something to do that, okay? You may have to help them a little bit with it. With mental status, you've already assessed it. You've already talked to your patient during your assessment. You've been discussing it. You've seen them moving things, or you've seen them not moving things by asking them questions. You can specifically, if you're worried about something with their mental status, you can say something like, hey, I'm going to assess you, but can you remember the word apple for me? I'm going to ask you in a little while. You can specifically say that. And then you do your full head-to-toe assessment. You talk to them for a while, and you say, hey, by the way, what's that word I wanted you to remind me of? Apple. Or, if you don't want to be as clear with that, you could say, hey, I'm going to have lunch in a little bit. I'm going to have spaghetti. And you ask them later on, hey, what was I having for lunch today? Spaghetti. Cranial nerve function, table 22.5. Understand the cranial nerves. You may not be able to memorize every single one of them, but we want you to know what they do and why they're important, okay? With the cranial nerves, they all focus on different parts of the face and other parts of the body, but this is how we look at it. If you've ever heard of the idea of FAST with a stroke, this is what we're talking about. With F, you're looking at your face. Does something look weird with your face? Asymmetric, is one eyelid drooping? Or can they not get their tongue to go to the right side versus the left side? Can they not speak? What's their speech like? Is it slow? Can they not figure out words? Do they just stop talking? So don't forget, this is what we're talking about with these. Again, you may not be able to memorize all of these just yet, but they are very important to know. Neurologic symptoms with the reflex, I want you to know that the normal reflex for assessment is a +2. It's a 0 to 4 score, but a 2 is normal, whereas 1 would be diminished, 0 is nothing, 3 is strong response, and 4 is extremely hyperactive response. So if you've all kind of seen that video with somebody like tapping their knee and you see a slight kick, if you were to tap the knee of somebody with a 0, nothing would happen. And if you were to tap the knee of somebody with a +4, they'd probably kick you out of the room physically and not mean to. Like, it's just a huge response to it. You also want to check any sort of reflexes bilaterally. So if it's a +2 on the right side, it should be on the +2 on the left side. And if it is different, you would notate that. Sensory function. There's lots of different ways to check that. They may have been complaining about a smell or anything, or they may have said, "No, that lunch smelled bad." But you can have them, have them do things to help with it. Excuse me. I'm trying to. 1 second. You can do things like smelling salts, etc. It's not done very often. But one of the other assessments that you look for sensory function would be numbers and letters. Have them close their eyes and draw an A on their hand, or something else like a Z, an F, something, and see if they can figure that out. See if they can tell you what letter it is with their eyes closed. They have something called 2-point discrimination, where you can take your fingers and put them on their skin and see if they can recognize if it's separated apart. If it's 2 points, the closer you get together, the more likely they are to feel only one. I tend to do that with pens, so it's a little finer. And then the location, have them close their eyes. If I want to see if they can feel everything. So if I have them close their eyes and I touch their left upper arm, I'm going to tell them, I'm going to touch you on one of your extremities, tell me where I am. And when I touch it, they should say left arm or left bicep or whatever they're going to say with it. So it should make sense to you. Genitourinary, I asked them. You need to be able to at least ask them. This is a very invasive assessment. You will be assisting with it, but MDs, PAs, nurse practitioners, these all will actually do these more invasive assessments. But if somebody says, I'm having a hard time urinating, or there's a catheter in there to help them urinate, and it's really irritating, you will have to go look and see if there's something wrong, see if there's something bleeding or irritated, see what you see on there. But a full invasive approach is done by providers. For males, look at figure 2220 in the book, but you're looking for hernias. You're asking them if they're having a hard time going, and do they go a little bit and then stop and have to keep going back and forth? Are they going 6 times a day? Do they wake up and pee multiple times a day? Do they have any bulges in their abdomen? Did they have abdominal surgery and now they may have a hernia showing? For the female, this is both an external and an internal exam. This is mostly done by females for comfort reasons, but what do you see when you do this? You see any redness or drainage? What's the pubic hair? Is it off on one side? Has it been shaved? The speculum exam is not something a nurse does, neither do they do the bimanual exam, but you can look at the skin, the genitalia, the pubic hair. And the pap smear. Now, you all may have a slightly different, or a different reading down there. I went through and found an error. I think it says 21 to 30 yearly. Delete that. And it should be 21 to 65. A pap smear is done every 3 years. And from 30 to 65, an HPV test is done every 5 years for current recommendations. Anus, rectum, prostate. For females, the anus rectum test is checked, or the anus and rectum are checked after the vaginal exam. In the male, you have anus, rectum, and prostate. That would be happening after the genital exams. You look at hemorrhoids. Are they dilated, painful? We're looking at hemorrhoids. We're looking to see if there's any bulges at the rectum. Oh, yes, I can go back if you want to hear those ages again. It's on this slide right here. 21 to 65 is 3 years, and 30 to 65 HPV test is done every 5 years. 21 to 65, 3 years. 30 to 65 HPV every 5 years. You're looking for rashes, any sort of situations that are down there. Do you see any skin breakdown, etc.? With hemorrhoids, something you want to know, if somebody comes in and say they see blood in their stool and they're worried about a GI bleed, check for hemorrhoids. They may have a hemorrhoid that's erupted and leading to painful passing of stool, and then blood is passing that way. You're still going to check it, but that would give you something to work with and the provider to work with to see if that's the only cause of the bleed. Okay. Oh, okay, we can do some questions. It would be most important for the nurse to include the fingernails in a basic assessment for client with which type of condition? I see a lot of C's. I see a D. Okay. I See a lot of C's and D's, which we're going through. So most important, critical thinking, most important. Integumentary, yeah, we were looking at some skin. Neurologic, we knew was out of it. Musculoskeletal, we knew was out of it. But the answer is actually D for respiratory. Remember, we're looking at, we also, of course, have the clubbing we're looking at, but we're looking for cap refill, which we're looking for that hypoxia, cyanosis. Okay, so we're looking at respiratory for that answer. Let's see. Patient is admitted with shortness of breath, so the nurse immediately listens to his breath sounds. Which type of assessment is the nurse performing? See. Oh, yes, absolutely. Focus. I'm not going head to toe. It's not an ongoing. It's not comprehensive. It's not psychosocial. I'm not going to ask them if they have access to food and water. I'm saying you have a problem with your lungs. Let's go check out your lungs. Absolutely. Focus. The nurse must examine a patient who is weak and unable to sit unaided or get out of bed. How should she position the patient to begin and perform most of the physical examination? People have been looking at those pics I gave you guys for those positions. Yes, B, semi-Fowlers. Semi-Fowlers is it. Okay, it's the most comfortable for that patient as well. Over what tissue should you expect to hear resonance? A, B. Okay, so I'm seeing A's and B's. So let's go to the wrong one. So bones, no, I'd expect it to be dull. Bones are full. Brain, no, don't start tapping on the brain. Please don't do that. The stomach and lungs, okay? So the stomach has fluid in it, but it's not going to be resonant. Resonant is empty space, okay? It's a large area. So lungs are empty, filled with air. That would be resonant, B. What position is correct for inserting a rectal suppository? For those of you who don't necessarily understand some of these questions, positions, make sure that you go through and look at those positions and understand them, because these will help you and you get these questions. These are examples of NCLEX questions. So Sims B, absolutely best position for that. All right, let me stop sharing. Questions. 22.4, thank you for that. I tried to go through and fix all the tables, so we have a new textbook. So 22.4 would be the cranial nerves. Normal amount of vowel sounds, 8 to 10, 8 to 12. Your textbook says it actually twice in 2 different methods. But it shouldn't be like 40 or 1 or 0. Okay. So we said that one. What was the normal amount of vowel sounds? We've explained that. Is pain subjective or objective? Soapbox. Current standards are now subjective only, no longer considered a vital sign. However, that's going back and forth between different policies, providers, and guidelines. So right now, it is considered subjective. Can you go over slide 26 and the 22, 3, 4, 5, and 8 to man? Oh, yes. So I know exactly what you're asking about. So what we're talking about with 2, 2, 3, 4, 5 is where you do the intercostals when you auscultate. So 2, 2, 3, 4, 5. What it is we're looking specifically for you to auscultate in those areas. Second intercostal space, right sternal border, second interspice, left sternal border, 3, 4, and then 5 is second intercostal space, mid-clavicular line, so you can actually assess the heart. That would be aortic, pulmonic, herbs, tricuspid, mitral. 2, 2, 3, 4, 5. Can you talk again about heart sounds? What was the question about heart sounds? What do you mean by talking about them? Like, there's different heart sounds. There's murmurs, which is extra sounds. But again, you can hear lub dub, which is what you want to hear, but you may hear whoosh, lub, dub, loosh, whoosh, lub, lub, lub. You may hear different sounds. All you want to know is what the normal is, lub, dub, and be able to recognize if something's different. Slide 23, with the Rhine test, when do you mean by, okay, AC and BC, air conduction and bone conduction is what we're talking about with Rhine. That's what I was talking about with bone. I just wanted to kind of introduce to you what Weber and Rhine is looking for. Weber would be more hearing. That's why I put my W here, because it helps remember. Weber is beyond here. It lets you hear bilaterally, so I should be able to hear in both ears. Rhine, specifically when you do it, will vibrate your bones and let you hear how long you're actually hearing something through the bones, and then you'd hold it next to your ear and see how long you can hear it. So that would be how long the bone conduction lasts and how long the air conduction lasts. That's what it's looking at. Feel the thrill. Okay, when feeling the thrill, remember how I was saying when you palpate, if you feel like an actual like bulging sensation of the vessels, you have a large or like a +4 on the pulse, you start going and you assess it, and you can feel that large amount of blood flow through that. That's a thrill. Okay. With slide 45, how do you screen for kidneys? Let me take a look at slide 45 to make sure I have the right one we're looking at. I can't see you guys. Hold on a second. Slide 45. Rectal exams, kidneys from the back. Oh, yes. Okay. So for the kidneys, I'm glad you said that. So for the kidneys, there's a couple different things, but the main thing you can do, especially if somebody says they've got lower back pain on one side versus the other, what you do is you cup, let me stand up. You cup their back like this, where their kidneys are, retroperitoneal, just below the rib cage. And then you take your fist and you tap it. Don't punch them or they're going to punch you. Tap it, okay? If it is a kidney infection, they're going to jump out of there. They're going to jump out. And they're going to be like, oh my gosh, ow. Done. You've got it. Kidney infection, kidney stones tend to do that as well. But if they have that and it doesn't do much besides like, oh, maybe it's a musculoskeletal issue. So that's how you assess those kidneys. Oh my goodness, all these messages. I'm trying to catch up, I promise. Let's see, will we practice with, yes, 2, 2, 3, 4, 5. You will practice that in lab as well and clinical. Can vital signs such as BP and HR be considered both subjective and objective if the patient is telling you their blood pressure is low, high, or their heart is racing? Yes, if they tell you it's low or high, that's subjective. Unless I measure it, it's subjective. Herbs, Tamara, I don't understand the question. I'll get there. What do you mean by herbs? Oh, herbs, you're talking about herbs point, I bet you. ERB. What it is that's the third, that's 2, 2, that's the third one. It actually is checking both atrial and pulmonic, but it's checking a large section of the heart when you're at herbs point. And Pam enjoys taking meds. Okay, perfect. What was the mnemonic for 2, 2, 3, 4, 5? Oh, oh, look, I answered that one, Jennifer. I hope that helped. Aunt Pam takes meds. That would work too. Aunt Pam, yeah, but you'd be skipping. I just add the herbs point because it's easy to remember 2, 2, 3, 4, 5. When describing the skin, what is modeling? Modeling is a cold or a decrease in blood flow to an area, becomes almost plastic looking. Happens a lot in cold patients, people dealing with hypothermia, as well as people close to death. And the bluish marbling. Yes, Kelly. Okay, I think, oh good, I caught up. Can you talk about A and Perla again? You skipped my, oh, yeah, Brianna, I'm sorry. I'm trying to catch all the answers. So yes, Brianna, feel free to throw that back in there. I didn't mean to skip it, I promise. A and Perla, accommodation. So pupils, I'm in a dark room. Let's see, I wonder if I can do this. We're dark enough in here. Look at my pupils, okay? So we've got pupils are equal. They're both the same size, okay? They're both round. They both should react when I do this. You should see my pupils change equally. They react to light. And then accommodation. We got the 6 cardinal fields of vision, which is when we did this to actually make sure that their eyes can move. But accommodation is specifically taking this, taking it towards their face, and their pupils, I don't know if you'll be able to see it, but their pupils should actually constrict as you get closer and then actually get wider as they pull farther apart. Let's see, Brianna, I'm trying to find yours. Okay, what about on a woman? Is it harder to hear these sounds or find the apical pulse with the breast in the way? I think, okay, yes, Brianna, so that was your question about that. No, it is not harder to feel. The apical pulse, you'd hear it, you'd also could palpate it. Let me say this one thing about women. If you need to lift the breast, it's the back of the hand, let them know what you're about to do because you need to make sure. John's totally shaking his head. You need to absolutely do it. When I was in nursing school, the scariest thing I had was, what do I do with a woman's breast? Because I have to assess them. So how do I take care of this? Back of the hand and let them know what you're about to do, and you lift the breast to get down there. I'm on the wrong side, but anyway. But yeah, you lift the breast to get where you need to be, okay? That way you can tell them what you're doing and you can do it. And then once you've lifted that breast, even if it's a pendulous breast, you can lift it and you can even put your hand there and feel that PMI on a normal individual. Brianna, does that help you? Jennifer, we've got time. If you've got questions, do one at a time with it because it's only going to help your peers. Assessment is my kick. I love assessment. I love so much about it. There's so much cool stuff you can find. So you can ask them to lift the breast themselves too if they can, are more comfortable with that. Absolutely, Chloe. You can absolutely have them lift their own breast with it. I was just giving more of an example specifically for the men because I remember worrying, what do I do now? Okay, I'm going to try something. Let me turn the recording off.